slide. So hopefully my disclosure showed there first. I've received research grant support from most of the major manufacturers of troponin. And I want to, lest you run from the room screaming, crying, or in a fog from what you've heard so far, I really want to bring us back to a clinical context. And Alan asked me to give a discussion on the help that moving towards sensitive and high sensitivity assays can give us clinically. And I also might even reframe my title to say a bit of a how-to. I'll try and give you some pragmatic advice. And I'll move between assays that we might call sensitive and those that are truly high sensitivity, because I want to give the clinicians in the audience an idea of how you can use assays that you have clinically available to you now. Because as you've heard from our presenters so far, there are no high sensitivity assays available in the U.S. at this time. So I want to ground us first in the clinical goals when you see a patient with chest pain in the emergency department. And from our ACC/AHA guidelines, we really have two fundamental objectives. The first is to assess the likelihood that those patients' symptoms represent ischemia due to underlying coronary artery disease. And the second parallel process is to assess the risk of death and recurrent ischemic events. And those two things together drive your effective triage and initial diagnosis as well as your treatment decisions. And I'll try and frame our use of sensitive troponins around those concepts. But I want to emphasize that these are clinical objectives, and you must use your clinical tools if you think back to Alan's last slide, and this can't be by biomarker alone. So first, let's start as a reference point. Why would using a high sensitivity or a sensitive assay add anything to what we've been doing for the past decade? And here is a reference point, is if you look at the diagnostic performance of the currently commercially available assay for cardiac troponin T and a patient who has a definite myocardial infarction, you know at this 24 hours this patient had an MI. If you're seeing them in the first 3 hours, your ability to detect that myocardial infarction is less than 50%. You have a sensitivity of only 43%. What we can do is if we use the sensitive, and this is from a sensitive currently commercially available assay, we dramatically improve that sensitivity. And therefore, we're also improving our negative predictive values. So when we're in the emergency department, we definitely have a leg up in our ability to detect those myocardial infarctions. Now, the downside expected is that you reduce your positive predictive value. And so we're going to pick up more events that won't turn out to be an MI at the end. And how does that pan out in terms of the overall diagnostic accuracy? And these data come from Christian Mueller's group that's in the audience, and Tobias Reichlin, who we're borrowing from him for a while in Boston. And this, though there are limitations to the study that Alan hinted at, I think this study moved the field forward, because as you look at the fourth generation commercial assay for troponin T that we're currently using in the United States, you see that each of these additional assays, more sensitive assays, dramatically improved overall diagnostic accuracy. And that's the first key important point, that moving to the newer assays has overall improved our diagnostic accuracy. The second thing that the newer assays have done is that they've enabled us to detect myocardial infarction very much earlier. So this is a group of 103 patients that we studied at the Brigham, who all by definition we selected them because we knew that they ruled in subsequently to their presentation, but their initial assay was not diagnostic. And you can see as we move to a newer generation assay from the same manufacturer, that group in purple, where none were detectable at their first sample, 60% were detectable with that first sample. So we were able to move that diagnostic forward in a substantial group of the population. So that's another potential advantage from application of the more sensitive assays. And this has translated now into a number of rapid rule-out strategies that have been studied in the emergency setting. And I'll focus your attention first on the left-hand side. This comes from the group in Australasia, and you can see Mark Richards' group, and you can see in just under 2,000 patients who presented to the emergency room with a possible acute coronary syndrome, in a strategy that applied the TIMI risk score and, so clinical criteria, and cardiac troponin measured at 0 and 2 hours, that they could achieve a negative predictive value of 99.7. So if you had stable troponin values that were negative below the 99th percentile within that time frame, low clinical risk, that you could exclude acute coronary syndrome with a very high degree of reliability within that study. On the right-hand side, you see a work from Tobias Reichman that was published last year in Archives, and this laid out 3 different groups of patients in using a 1-hour strategy with a high sensitivity troponin T. And what you can see is that if you had a baseline concentration at 0 hours that was less than 12 nanograms per liter, and your delta was small, so it was less than 3, that in that group of patients you could rule out myocardial infarction within 1 hour of measurement with a sensitivity of 100% and a negative predictive value of 100% in this particular cohort. In contrast, at the other end, if your troponin was already above 52 nanograms per liter at 0 hours, or you had a significant delta by 1 hour, then the probability, the specificity for ruling in was 97%. In the middle, you had a gray zone where you needed additional testing beyond that hour. But this allowed you to take 60% plus another 17%, and within 1 hour categorize patients into these diagnostic bins. And that is a potential advantage for emergency departments where there's substantial overcrowding and throughput. I do want to highlight that I think we're very early on in this process of knowing how to use these early rule-out strategies, and I personally don't know that they're ready for clinical prime time, but these 2 studies show us where the field is moving for sure. So let's move now to prognosis, and I want to come back to the same study from Tobias Reichman in the emergency setting, and now focus your attention on the right-hand side of the slide, and here you see prognosis. And so in that group that ruled in within 1 hour, you can see that their survival over the ensuing 2 years was markedly impaired compared to the low-risk group that ruled out rapidly. And I think this portion of the curve is actually the most important, because I think that's the group that we worry about most in the emergency department, is that are we going to send patients home too quickly who are actually at high risk for early death or recurrent ischemic events. And at least in this data set, using this algorithm, the data are reassuring that there's a very low short-term and long-term risk in that particular group of patients. Now, if we turn to patients who have a clinical syndrome of acute coronary syndrome, where our clinical probability of ACS is quite high, you can see, and we've shown with several different assays that have moved forward to become more sensitive. This is not a high sensitivity assay, but one that's currently commercially available in the U.S. And we found that you detect about an additional 7 to 12% of patients who you would not be able to pick out with your current, with previous generation assays, and this group is represented in the yellow. And here are their 1-year outcomes. We had 4,500 patients in this study, and you can see that indeed their risk of death or myocardial infarction is nearly identical to those who had elevations that would be in a range that we could detect with previous generation assays. So first, we've seen that there is the ability to detect with greater sensitivity. We can detect more rapidly. And now we also see that those patients with those low-level elevations, if they have a good story, a good clinical story for ACS, are indeed at high risk. So we're not picking out some inconsequential population that's at lower risk. And this has been recapitulated in the GUSTO-4 study with high sensitivity troponin T. And I'll focus your attention on the yellow bars on both of these, because these are the patients who the 4th generation assay, so the previous generation assay, was not elevated, whereas the high sensitivity was. And you can see in that group of patients, they were at significantly increased risk, both at 30 days and 1 year, for death or myocardial infarction. And we have consistent evidence now from at least 4 studies that have shown that the more sensitive assays, including some data with a high sensitivity T at least, show an increased risk. Now, what about clinical implications? And this is a real-world study from the UK using a sensitive assay, so this is not a high sensitivity assay. This study was observational, so we have to take it with those limitations. But nevertheless, I think it does give us clues to the way forward, and also gives us some reassurance that clinically the move toward higher sensitivity assays has offered us an advantage for our patients. So you can see that in the upper bar is where the study started, and this was with the validation phase in which a new sensitive assay was applied at this in this group of patients. And initially, they left their cut point diagnostic for myocardial infarction at 0.2 nanograms per ml. And that actually was an inappropriate cut point. It was higher than the 99th percentile. But nevertheless, as they moved to a new assay where it had shifted down the 99th percentile, they wanted to be cautious and evaluate that change. And what you can see is when you look at survival-free from death or recurrent myocardial infarction, that middle group, and I'm going to use a strong word, was ignored, or at least not recognized as having myocardial infarction, actually had the worst outcomes. And their outcomes were worse than those patients in the dotted, the hashed lines, who had more myocardial injury, but were recognized in the current diagnostic parameter as having had myocardial infarction. Then in the implementation phase, they now recognize that this middle group at 0.05 was indeed a, quote, positive assay. And when you do that, now the outcomes are shifted. They found that they had higher use of evidence-based medications, and the outcomes were now similar to those patients who had higher levels of troponin. This is not randomized. This is not definitive evidence, but it is an important clue that we are moving in the right direction by moving to more sensitive assays and recognizing the appropriate guidelines-based cut points. So now, with everything I've said so far, why are a lot of us pulling our hair out in the emergency department sometimes when we get patients with low-level elevations, and why is there some trepidation about using more sensitive assays? And these data from Jim Januzzi, who will be our next speaker, are very important in illustrating what we have to recognize as the limitations, particularly when we apply in patients with a low to intermediate probability of acute coronary syndromes. So this is a lower risk. Now your clinical story is not as good. There are much broader diagnostic possibilities. And here you can see the positive predictive value of a high sensitivity troponin was less than 50%. That means that with a positive assay, that patient was more likely to have a diagnosis other than myocardial infarction than they were to have an MI. And that's the struggle that we have when we apply troponins broadly in patients with a low clinical suspicion. So this might lead you to say, okay, fine, it's all hogwash then. I'm just going to ignore these low values with the high sensitivity assays we're measuring in far too many patients, which may be true, but it doesn't mean anything clinically. But the second part of this study evaluated evidence for underlying structural heart disease in those patients who had a clinical diagnosis that was not ACS. But you can see that those patients were much more likely, if they had a positive high sensitivity troponin, to have other risk factors for structural heart disease, diabetes, or a definite history of coronary disease. They were more likely to have regional wall motion abnormalities on their echo. And they were also more likely to have a greater burden of coronary artery disease on CT angiogram. That's rather important. So it's not that those elevations don't indicate something clinically relevant. It's just not that this is acute coronary syndrome. And that, as other speakers before me, and Jim will no doubt speak about next, is really where you need to move in your clinical applications of the assays. So here's the updated third universal definition of myocardial infarction, a key figure from this document. And it reminds us that to make the diagnosis of myocardial infarction, we need both evidence of myocardial injury with a rise and fall of cardiac troponin and clinical evidence of acute coronary ischemia. But there's a broad spectrum of other settings in which there's myocardial injury, whether that's reversible or irreversible. I'll argue doesn't matter that much clinically. It's more what it means in terms of prognosis, where we see myocardial injury. And this is our challenge as clinicians to recognize these. And as we've moved toward more sensitive assays, we've dramatically increased our ability to detect myocardial infarction, which is a good thing. We've also increased our ability to detect these vast other arrays of myocardial injury due to other syndrome, and that's the clinical challenge. I don't think it's necessarily intrinsically a bad thing, but it certainly makes our job more challenging as clinicians. And here's the list. Beyond myocardial infarction, here are all cases of type 2 demand-related myocardial ischemia. Then there are other forms of injury, myocardial contusion, rhabdomyolysis, myocarditis, cardiotoxic agents that do not relate to myocardial ischemia and therefore are not myocardial infarction, but do relate to prognosis as myocardial injury. And then there are a long list of things that may have multifactorial contributions in heart failure, where ischemia may be a contribution, but also just increased wall stress, or apoptosis and other forms of cellular injury. And now it's important to move into your clinical vocabulary the universal definition of myocardial infarction classifications, where we recognize what we've always regarded as acute coronary syndrome, spontaneous MI, type 1 MI, the long list on the left of causes of demand-related ischemia or non-plaque rupture-related ischemia, such as vasospasm, that constitute type 2, and then other causes. And then I'll say that all of these are related to increased risk of outcome. We can debate whether they're similar or not, whether they're the same, but they all relate to subsequent adverse outcomes. So how can we apply this in the real world? Well, I think in the patient with low probability of ACS, our job is not to say this is a clinical false positive. Our job is to say this represents myocardial injury. Let's try and sort out the cause, and particularly to identify those that may improve prognosis. We look for ischemia, other causes, and other forms of structural heart disease. Alan already said that those with myocardial infarction are going to be higher. Now, there is some overlap with other causes of myocardial injury, such as PE, but they're, for the most part, if they have a high absolute value, it increases the pretest probability. Use the delta. If there's a significant change, we know that it's dynamic, and that also increases the probability that it's myocardial infarction. So here's what I do clinically. I first look for another obvious cause of acute other cardiovascular cause, like pulmonary embolism, myocarditis. I also consider possible non-cardiac causes, such as severe sepsis. If there's demand myocardial ischemia, I treat them medically, and I look to complete risk stratification down the road. Unstable coronary disease, I treat, as we all know, per guidelines. And then last, I consider, when I've excluded all of these, I consider other potential causes and underlying structural disease. And that's how I apply the clinical assays. If you can go ahead, at least turn off the beeper. And that's an approach to using these assays clinically, and to recognize at the end of the day, you don't want to ignore these elevations. It's not send the patient home and close your eyes, but rather recognize that those patients who don't have ACS have likely other underlying structural heart disease and need additional risk stratification and follow-up. I thank you very much for your attention.
Thank you, David.